Well, and there's our minute because that's my cue to get going on it. So welcome to our IDRPP Early Intervention Echo. We're glad to have you here today. We are recording. We store our recordings on our Canvas page as well as our YouTube channel. So you can go back and review the information and share it with your colleagues, or if you just need to digest what is being shared, they're always there as a resource with it. Echo is an interactive community, so please put your questions into chat, be engaged. If you're willing to turn on your camera, if you'll turn on your camera, makes it so much nicer as the presenter or as just a participant to know and see all these amazing faces that are on the call. We do talk about some sensitive information. If you are asking a question or putting anything in chat, please remember to protect the individual privacy. If you have any questions about what you shouldn't do, you can reach out to one of our amazing hub members who all have an asterisk or will be reminded right now to rename and put an asterisk in front of them. They're just easier to find that way in chat. Key components of an Echo session. Once again, if you're just new to our Echo community, welcome. We will always have a didactic speaker, so someone who presents a topic. Today we have a great one on hearing loss from Stephanie. And then we also have a case presentation where we then talk about that case, and you all are able to share all your amazing resources and recommendations for the case presenter. That really does help us build that professional networking, so that if perhaps Rebecca Foster said something during the session or during my breakout room, that I'm then able to know I can reach out to her and ask for follow-up questions or also brainstorm different ideas with her. Renaming your profile. We've all been on Zoom forever now, it seems like, and Zoom just updated. So today it's a little bit different than what it's been in the past, but if you'll take a minute to rename your profile, where you're from, what your discipline is. Again, it just helps us know in this virtual world who is on the call and where we can connect. We will be dropping throughout today's session a survey link, and that is how we send out our credit for attendance. When you complete that survey, we do then monthly send out a credit for attendance that you can use for continuing ed or turn into your local organizations. Canvas is where we store everything. So if you want to have access to our Canvas page, please just email us at earlyecho@usu.edu with the subject line Early Echo Canvas, and we'll get you set up on our Canvas page. Case studies, we are always looking for case studies. They are a great way to learn from everybody that's on the call. I know that I have been a case presenter several times, and I always love it because it gives me a ton of resources that I can take back to the families that I work with, and just also the colleagues here in my Part C early intervention program. So please consider doing that. If you are interested, you could reach out to earlyecho@aggies.usu.edu, or Kate Bennington. She is also one of our amazing hub members who helps us recruit those case presenters. If you've not followed us on social media, if you want to take a minute to scan those QR codes, we try to put information that is shared with us from either past participants or things that we get via email. So we do share some information on there. And then I'm going to stop sharing, and I'm going to turn the time over to Stephanie who is going to be talking to us about hearing loss. And bear with us, we practice the, look at, she's amazing. But Stephanie, you're on mute, so we can't hear you.
Well, it's really good to see you all here today. Thank you for the invitation. I do recognize some names that are on here. And I am Stephanie Browning McVicker, and I work at the Utah Department of Health and Human Services. And my clinical background is in audiology, specialize in infant and pediatric audiology. And here at the department, I am the program manager for the early hearing detection and intervention programs, otherwise known as EDI. And in Utah, we do have 3 audiology related mandates, and they're considered collectively our EDI program. So we have our main early hearing detection intervention program, which is newborn hearing screening and its follow-up. Then we also have our congenital cytomegalovirus public health initiative, which has an education and a testing component. And then our children's hearing aid program. So this is our EDI team, and there are 9 of us, and we do have 3 audiologists on our team that call us Etiologists. And we have, I'm pointing out, we have 2 wonderful parents of children that are deaf and hard of hearing, and those are what we call our EDI parent consultants, and they provide parent-to-parent support and resources and events across the state of Utah. I know I'm preaching to the choir here because you all work in early childhood of some way, shape, or form, but we all know that the early years of a child's life are absolutely critical for brain development and making those wonderful neural connections. And one of the things that is absolutely necessary to know is how their child's hearing is. And so if there's hearing loss, those connections aren't going to happen until the hearing loss is diagnosed, and then resources are given and support to the child. Now, before we had universal newborn hearing screening, the average age that children were diagnosed wasn't until 2.5 to 3 years of age. And so that was essentially missing the critical window for the development of speech and language and communication. And most of the times the children weren't picked up their hearing loss, there wasn't a concern really until the child was having speech and language delays. Because even a child who's deaf, they will babble. They eventually will stop. But if they have some residual hearing, that child, even with a severe hearing loss, if someone slams the door, they're going to startle, and they may act like they're hearing, but hearing loss is a spectrum. When just from Utah data, only 10% of the hearing losses that we diagnose at birth here in Utah are what we consider profound hearing loss or otherwise deaf. The other 90% that we diagnose is a spectrum. They are hard of hearing. And so if there's hearing in the low frequencies and not the high pitches, I mean, that child is still going to be responding to sound, but they don't have adequate hearing for developing speech and language. The good thing is, after universal newborn hearing screening, we're now diagnosing these children at about a couple months of age. We try to diagnose children before their three-month birthday. And so there's been a huge difference. And in our state, we've been doing it since 1998, and all of your states also have been doing universal newborn hearing screening for a long time. The Joint Committee on Infant Hearing is a national organization, and they put out guidelines on early hearing detection and intervention. And they have what is referred to as the EDI 136. And those are the milestones that all the states and territories ascribe to. And that is that every child that's born needs to have their hearing screened before 1 month of age. Those who do not pass need to have a diagnosis, a diagnostic evaluation before their 3-month birthday. And those that are diagnosed as deaf or hard of hearing do need to be enrolled in early intervention before 6 months. And research has shown it's very important that each milestone is attained. So the 1 and the 3 and the 6. It's not enough to meet one and not the others. this is so important, and this is keeping our eyes on the prize, is we need to hit these milestones. And now national EDI programs, they're now looking at language outcomes. What has happened with us all working so hard to make the 1 and the 3 and the 6 on these children? And so the next reportable metric that we have is language acquisition outcomes at the age of 3 for deaf and hard of hearing children. That's our latest HRSA funding, our latest project. That's the big push, is to get these language outcomes to see how we did. Now, reporting, all of the states and territories also, we do have to report how we're doing with the 1 and the 3 and the 6 milestone attainment to the Centers for Disease Control and Prevention every year. It's called the HSFS, or the Hearing Screening and Follow-up Survey. And if you want to know where your state is falling with meeting these milestones, you can just put down CDC EDI data, and their website with all of the national data will come up. Here in Utah, we do have a cytomegalovirus law that mandates children that fail their newborn hearing screening be tested for congenital CMV. I'm going to talk a little bit more about that in a few slides. So instead of a 136, all of our babies here in Utah do have to be screened and rescreened before a third of a month. So we have time to get CMV testing done before they're 3 weeks of age. And what's so important about that 21-day window is if a child is tested for CMV and they're positive and they're over 3 weeks of age, we can't differentiate whether it was an infection in utero, so a congenital infection, or it was an acquired or after birth infection. And so it's super critical to have these babies tested for CMV before they're 3 weeks of age. So here in Utah, and many states follow the same protocol, where what's called a 2-stage state. And I believe probably 2/3 of the states follow this. So every baby has a screening if they're born in hospital about 10 to 12 hours after birth. If they don't pass, then they'll be checked again right before discharge. So if they don't pass that final hearing screening in the hospital, they do return to the hospital and have a second screening as an outpatient. And our state protocol is that that is done no later than 10 days of age. Now, I want to give you a little audiology 101 here. So looking at the peripheral auditory system, when we see the external ear, we have the pinna right here. It captures sound. And if this is an interesting thing. So if you are sitting around a dinner table, like at Thanksgiving or whatever, and you're having a hard time hearing, there's the hand cup effect. If you actually cup your ear, you actually can increase the level of what you're hearing by about 5 decibels. So sometimes it's even more effective if you do that. Doesn't matter what you look like, but as long as you can hear better, that may be helpful. Little tip. So the pinna captures sound, it collects sound, it's going to direct the sound into the eardrum, because now sound is vibration. So we've got a sound wave that's traveling. It's going to hit the eardrum. The eardrum is going to move because it's just like the top of a drum. You know, it's flaccid, it moves. It sets these 3 little tiny middle ear bones. They're the smallest bones in your body. And all of them can fit on the head of a dime, all 3 collectively. So it sets these ossicles in motion. So the malleus, the incus, and the stapes. And then the stapes here, the foot plate of the stapes actually is going to push that sound wave into the cochlea. Now the cochlea is our sense organ of hearing. It looks like this little snail. And as you all know, the ear also controls valence. So there's another part of the ear that have what's called the semicircular canals. And they're what help us know where we are in space. And if there's something amiss with one of these canals, then people can experience vertigo, which is not a pleasant sensation. But we're not going to talk about the vestibular system today. And then lastly, we have the cochlear nerve. It's the 8th cranial nerve, and that's what sends the signal up to the brain where the sound actually gets interpreted and processed. Now this little guy right here, that's your eustachian tube, and it connects the back of your throat to your middle ear. So sometimes when people are sick and they have a sore throat and there's inflammation, this eustachian tube can get swollen. It can close off. And then, you know, sometimes when you're really sick, you feel like your ear is plugged. It's because that eustachian tube is closing. And then what happens, this normally air-filled space in the middle ear will get inflamed and it'll start to accumulate fluid. But a healthy ear is going to just be filled with air. So I want to show you, if we took the cochlea and we unroll that snail, this just shows you when the footplate of the stapes pushes that sound wave into the oval window, the sound wave will travel. And this right here shows that depending on the pitch or frequency of the sound is going to determine how far along that spiral the sounds go. Now, what happens is the sound wave travels. There's little hair cells that'll be put into motion. That motion will cause firing, electrical firing, which then is transmitted along the nerve up into the higher parts of the auditory system. So if we took a cross section of the cochlea and we sliced it right there, this is what we would see. And these little hair cells, outer hair cells, are very, very important for transmitting the sound and causing the nerve to fire. And I'll tell you why that's important, these little outer hair cells. Because one of the ways that we screen hearing, especially in newborns when they're born, is looking at otoacoustic emissions, or OAEs. Now, this screening can be done on anyone, so it doesn't just have to be on a newborn. But for example, let's say there is an adolescent who has a special healthcare need and they're not able to provide responses when sound. They can't be taught to do something when they hear a sound. So they can't do subjective testing. So you can do this test. It's quick and easy, and it's an objective test just to get a general sense of how those outer hair cells are functioning. So the reason why I say that is we put a little probe in the ear, sounds are delivered. Now, what has been discovered in the end of the 70s, David Kemp discovered that the cochlea is also active in generating sounds back. And they originally called it the Kemp echoes. It's not an exact echo, but for these purposes, just know that the outer hair cells in the cochlea, when they hear sound, if they're healthy, they will create another sound, which the little probe tip then measures. That's the emission, or the OAE. So it's quick and easy as long as the little baby or the person you're doing is quiet and not moving. We can get results within just a couple minutes. So it's quick and easy. One, if they accept the little probe. If it's a little tiny baby, it's easy because they just do a lot of sleeping. But if you're trying to do it on a toddler, that could be a different story because they don't really like having stuff inside their ears. So the patient has to be quiet and not moving, and then we can get an indication based on the level of those emissions, how well the outer hair cells are working, which are a key component of hearing. So it's kind of an indirect test of hearing or hearing loss. If someone has more than a mild hearing loss, the otoacoustic emissions will be absent, and that's a red flag. And then we know that they need a full-blown audiological evaluation. And I mention that because OAEs really are what's done as a screening test can miss a mild hearing loss. So someone can have present emissions, and the machine will say, because it's a machine technology for a screening test, will say pass, but mild hearing losses can be missed. So if you're working with clients and there's some concerns and they say, oh, but they passed their newborn hearing screening test, all it means is at that moment in time, they passed the screening, and hearing can change. There can be late onset hearing losses. There can be progressive hearing losses. And it could have missed a mild hearing loss at that point. So it's a good screening test, just like any universal newborn screening. It's looking at capturing the most severe cases. So just remember, it's not 100% and it can miss mild hearing losses. Now, there's another screening test that we do. Now, to compare it to the otoacoustic emissions, the otoacoustic emissions is an indirect test of the external, the middle ear, and then also to how the outer hair cells are functioning. But if there's a problem farther in the auditory system, past the outer hair cells, like in the nerve, a child can pass an OAE and still have a neural problem in the auditory system. And you may have heard it called ANSD, or auditory neuropathy spectrum disorder. And that means that there's an insult further up the auditory pathway beyond the level of the outer hair cells. And so if we do an automated auditory brainstem response, or AABR, and the child passes, we have a pretty good idea that that nerve is functioning well, But again, that can still miss mild hearing losses. The thing to know is auditory neuropathy spectrum disorder is much more common in infants that have been in the neonatal intensive care unit. So about 90% of cases are in NICU babies. And so the JCIH, that joint committee that I mentioned early on, they do have in their guidelines that if there's a child who has been in the NICU, they need to be screened with an automated ABR at a minimum, just because there is a chance they could have auditory neuropathy. And again, this is a screening, mild hearing losses can be missed. So what happens? So at the outpatient screening, if the child passes, they're referred to medical home for ongoing monitoring of speech and language and hearing development. And again, it's very important to always take any parental concern that their hearing loss could still be present. It could have been missed if it was mild at birth, and then also it could have been a late onset or progressive. So had a slight hearing loss at birth, but it's gotten worse as time goes on. And congenital cytomegalovirus is the biggest one that is known for doing that. So having a late onset to the hearing loss, and then also having a progressive nature to it. If the child fails, they do need to see an infant and pediatric audiologist who will do a full-blown diagnostic ABR test. And then here in Utah, the child goes right to the lab and we have the CMV testing done. Just an FYI, it's done on urine or saliva. Urine is the gold standard. Saliva is quick and easy to do, but there is a caveat that you have to wait 2 hours after the ingestion of breast milk, because if there's CMV in the breast milk, it can give a false positive from the test. So sometimes it's hard, especially if it's a newborn and they're really, really hungry. So let's just quickly talk about congenital CMV. And I know the case study that Kate's doing, I'm excited, is about a child who's been affected by congenital CMV. So that'll play together nicely with this. As I said, we do have a law here that mandates hearing targeted testing. So if babies fail their newborn hearing screening, they do need to be tested. Just an FYI, and again, I'm assuming I'm preaching to the choir, but CMV is ubiquitous. It's everywhere. Most people have been affected by it by the time they're middle age. We're about 60 to 80% in the US have been affected by it. And people are, why is it not common knowledge? Why aren't people talking about CMV? Well, unfortunately, well, actually it's fortunately, but because it's a silent virus for the most part, most people don't really feel sick with it. And if they have a strong immune system, they're going to be just fine. Those that do have symptoms, they mimic the flu or mono. So their spleen or their liver may be a little enlarged. But the problem comes in, well, one, if there's a compromised immune system, CMV can be fatal. So someone who's on immunosuppressant medication after a transplant, or if it's a person who has a compromised immune system, let's say they have lupus, an autoimmune disorder, CMV can be deadly. In pregnancy, a pregnant woman, if she gets CMV, it can affect the baby growing inside. Now, it's not 100%. So there's about a 35% transplacental effect of the virus. So about 1/3 or so of babies growing inside, that virus will cross the placenta and infect the child. And what do we know? We know that of those children, again, that's not 100%, that there's going to be an issue for that child who's been affected in utero. About 1 in 5 babies will have significant consequences from having a congenital infection. Now, our law started in 2013, so we have data now for over 11 years, and we're finding more than about 1 in 4 are having issues instead of 1 in 5. Now, developmental disabilities, seizure disorders, cerebral palsy, sensory neural hearing loss is one of the most common symptoms, vision loss, and there's a spectrum. So just because a baby's been infected in utero, they still may be born and they don't have any signs or symptoms or consequences. But ones that are affected early on in the pregnancy, in the first trimester, are more likely to have significant issues. And having a congenital CMV infection can cause stillbirth, it can cause fetal loss, and it can cause death during early childhood, often from uncontrollable seizures. So it can be very, very devastating. National incidence is about 1 in 200. So in Utah, it's estimated with our birth rate about 250 are born a year. We're not screening universally, so we're not capturing 250, but we are capturing babies that are detected from our hearing targeted law. And then we also have babies that are being tested in a high risk protocol as well. I just want to give you this data of our hearing targeted babies. So they were tested just because they failed their newborn hearing screening. About 1.6, 1.7% of them do have a congenital CMV infection. So it's a pretty high hit rate, even if they're just being tested if they fail their newborn hearing screening. I already talked about the 21 days and why that's critical. I talked about saliva or urine. Saliva, if it's positive, they do need to have a confirmatory urine before 21 days of age. We do have a congenital CMV clinic here. So for those of you in states that are outside of Utah, we do have a multidisciplinary clinic here up at our primary children's hospital, and they have infectious disease and neurology, ophthalmology, otolaryngology, and we have had individuals that have congenital CMV who have flown up to Salt Lake City for a weekend where they get admitted and then they get all of their testing done and get their specialty services. So just keep that in mind if you do have a child who's born severely affected with congenital CMV in your state. And again, why are we doing it hearing targeted? Just because it is the leading non-genetic cause of hearing loss in children. And as I mentioned, there's often half the time we'll have a late onset to the hearing loss. It's often progressive in nature. And so the follow-up for audiology is very, very strict. So we want to follow these kids every 3 months until the age of 3 years, every 6 months until the age of 6, and then annually thereafter. So we're very conservative when we're checking these babies. All of the data that we've been capturing these past 11 years do show it's during that first year of life, and then up until like age of 2 to 4, those are the highest groups where we start to see the hearing loss change considerably. And we do know if a child has a unilateral or 1-year hearing loss, they have a pretty good likelihood of having the other ear eventually being affected as well. Just so you all know, because you work with little ones, it's very common in group settings. So if there's a daycare, the CDC estimates 1 in 3 children are actively shedding the virus in their body fluids. I know that always sounds weird, shedding, you think things are coming off, but it just means that the virus is active in their body fluids. And what we do know is little kids have the virus in their system for quite a long time, much longer active than an adult has. There is no vaccine. There's many trials going on now, which are really exciting. And now I think I can say that I think in the next 5 years, I think there is going to be a vaccine that's available, because there are some in late stage trials right now. So what do? How do you prevent it? Well, it's universal. You don't know which child has has CMV period. So it's make sure you're not sharing body fluids at all. So if there's a mom that's pregnant and they're working around young children, if they have other children or toddlers in the home, make sure that you're not sharing food, drink, utensils. You're not cleaning a toddler's pacifier in your mouth. It can transmit through any body fluid. So you have to be careful with your husband. Wiping runny noses, blood, mucus. It can remain alive if it's wet on a surface. So disinfectant, and just an FYI, baby wipes, they have studied it, it's not going to kill the virus. And so if sometimes you change a diaper and you wipe your hands with a baby wipe, that's not enough. It might help get, superficial stuff off your hands, but it's not going to kill CMV. And so it's always important, if you're not by a sink, that, you have a hand sanitizer that your washing your hands with, and then as soon as you can get to a sink, wash again. And the same thing, wiping a surface with just a baby wipe is not going to kill the virus. When we get to the diagnostic evaluation here, again, it can happen where about 1 in 4 children we have. So if they fail their first and then their second screening, about 1 in 4 kids, by the time then they get to their diagnostic evaluation, about 1 in 4 of them do have a permanent hearing loss. So that means that 75% don't. So those children are again referred to the medical home for ongoing monitoring. Once they're diagnosed with a hearing loss, the federal guidelines, that joint committee again, an EI referral should be made within 2 days. And then they also recommend if the child is a candidate for hearing aids and the family is choosing to go that direction, that amplification should be started within 1 month of diagnosis. And then here in Utah, we do have a couple of specialized service providers for early intervention for deaf and hard of hearing children. And then also all of our children that are diagnosed get referred to our parent consultants for parent-to-parent support. And then on the medical end, they have all the specialist referrals so they can help determine etiology of the hearing loss. Just to go a little bit more into detail, when we do an ABR, now a full-blown diagnostics, the little one, we prep the child's head, we put electrodes, normally one low forehead, high forehead, or up at the apex here. And then we put them either on the earlobe or the mastoid. So we have 4 different electrodes. It's certainly best done on a completely sleeping baby because we're trying to measure an electrical change, which is the auditory brainstem response, into sound. That electrical impulse that's fired, and it's a very tiny microvolt response. So if there's any noise, movement, excuse me, crying, any of that, it can obliterate our little tiny response we're trying to measure. Now we know when we're doing the test, the waves that we're looking for, if it's normal hearing, this is a very typical normal response, and we look at waves 1 through 5. Wave 5 is very robust, and it's the one that's going to last the longest. So if you ever see an ABR done, you're going to see the audiologist sitting there and manipulating things and just watching and looking at all these waves. So what we're doing is we're changing the pitch of the sound, and then we're also changing the loudness. So we're measuring these waves. If we get a response, we're going to continue to decrease the intensity or the loudness of the sound until those waves go away. And that's what we determine is the threshold or the softest the child can hear. And it is tonotopically arranged so that these waves correspond to different areas going up into the brainstem. That's why it's called the auditory brainstem response. So this is an example of waves that have been generated. It's 70 decibels at a pretty loud sound. We get really nice 1, 3, and 5, very robust waves. This is normal. And also we're looking at the latency. So what do they look like? What's the morphology, and when do they appear, and how long do they last? So if we drop the sound down to 50, we start to see a little bit lower early waves. The wave 5 is robust. We're dropping down to 30 decibels now, a unit of loudness, and we're still getting a nice 5, and then all the way down to 20 decibels, which is really the limit considered at the highest 20 normal hearing for an infant. And you can see we no longer getting the early waves, but that 5 is what we're measuring. That's robust. And this ear right here to the frequency that we're doing would be considered to have a normal hearing threshold. Now let's contrast it to, yes.
There's a question that says you use the acronym AABR before. Is that different from ABR, or are they the same?
No, that's such a great question. The A stands for automatic. So the AABR is the screening test where the machine, you still put electrodes on the head, but the machine does the reading, and it's going to get responses automatically on its own, and the machine is going to decide whether or not it's a pass or a fail. So it's automatic interpretation. The screener themselves don't even get to see the waves. So anyone can be trained to do an AABR. The ABR is an actual diagnostic evaluation that has to be done by an audiologist that has expertise in this, in infant and pediatric audiology and this type of diagnostic testing. So an AABR may be done in 5 to 10 minutes. When we're doing a full-blown diagnostic ABR, sometimes it can be an hour, sometimes it can be longer if the baby is waking up and we have to wait for them to settle down. And so that was a great question. I'm sorry, I can't see the chat. So please, if that happens again, just holler out and I'll answer the question. So this little baby, this is the loudness levels. We're getting 1, 3, 5. We're dropping down to 80, 70, 60. We're still getting a little bit of a wave 5. 50, you can see those waves are gone now. 40, there's nothing. So here the threshold is at about 60 decibels. An average conversational speech loudness is about 50 decibels. So I'm speaking right now at about an average conversational level, so about 50 decibels. So that means that this child's ear isn't even picking up that I'm saying anything. And if we look at the right ear, because that was the left, the exact same thing. So there's no response below 60 decibels. So what we would say is this child has a moderate bilateral symmetric hearing loss. And this is just looking at, we look at all of the different important frequencies for speech. So 500, 1000, 2000, and 4000 hertz. And that's just giving us a picture at that one frequency that I'm showing you here, but to look at the configuration of the hearing loss, we do need to get a complete ABR that looks at all of those frequencies. When we're testing babies and we're doing these objective assessments, we're actually not requiring a response. So that's why it's perfect for infants or for those who have developmental disability or not able to appropriately respond when they hear a sound or indicate. So those are objective testing, but it's really important to have subjective tests as well. So we don't really know what the actual child actively is responding to sound. So remember how I mentioned auditory neuropathy disorder? So we may get indication objectively that the child may be hearing okay, but we put them in a sound booth and we're talking to them and we're playing sounds and the child is acting like they're deaf. So the objective test is measuring that there's stuff going on, but their brain or the nerve, wherever that problem is in the auditory system, isn't allowing them to interpret the sound and make use of it. So it's very interesting. When we're doing children under 6 months of age, and actually any child we're going to do, or even an adult, it's a part of our normal diagnostic assessment. There's something that we do tympanometry. Now, anyone who has children or as a child had a lot of middle ear fluid or ear infections, needed ear tubes, things like that, the best test to determine what's going on in the middle ear space is what's called tympanometry. Same thing, we're going to put a little probe in the ear. We're going to change the pressure in the ear canal. When we do that pressure change, if this is the ear canal and this is the eardrum, we're going to push on it with this pressurized air. This is the middle ear space. If this is a healthy middle ear and it's filled with air, we're going to measure the eardrum moving, and then when we relieve the pressure, it's going to come back. That's a normal. That's what we're looking to measure, that movement. If we push on it, and let's say there's a lot of fluid or mucoid or mucus otitis media or a really bad ear infection, when we press on it with our air pressure change, it's not going to move because it's got gook, so to speak, in the middle ear. That's not allowing that movement. So when we're doing that test, we actually get a reading that's called a tympanogram. So I mentioned the normal reading where we get the eardrum to move and it comes back. So this is a normal tympanogram, which tells us that middle ear is healthy. There's nothing in the middle ear space. So we can rule out if we're getting signs of hearing loss and the tympanogram is normal, we know that, okay, the hearing loss is not coming from a cerumen plug or completely occluded by earwax. There's nothing going on in the middle ear space. So it could be middle ear fluids, we know that's okay. Also, sometimes those little ear bones, especially if there was a car accident or whatever, they actually can fracture or dislocate or whatever. Those would all show up abnormally when we're doing tympanometry. And if you might have heard the word, oh, the tympanograms were flat. That just means when you look at this blue curve, we're pushing and we're changing the air pressure and we're getting a flat movement because there's something happening in that middle ear space. So that helps us determine the type of hearing loss. And as I mentioned, objective measures are great, but we also have to try and do some behavioral testing to really see if how that child is responding themselves behaviorally to sound. Now, there's something that we can do in the sound booth if the child's up to 6 months of age. It's called BOA, or behavioral observation audiometry. It's very subjective. There's an observer in the booth who has to be trained to look for subtle responses of the child. Now, it's a hard test to do, but it can give you some information. We're always trying to take many different tests to put the puzzle together. And what they're looking for is a change in behavior. So if the baby is actively sucking and we put a sound in and they stop, that could be the sign of a response. Or conversely, if the baby's just hanging out and they have their binky in their mouth, we usually like them to have a binky in their mouth. It makes it easier. If they're not sucking and then we play a sound and then they start sucking, that could be an observable response. Again, it's very subjective and it can be done really well and can be meaningful as long as you have a trained observer in the booth that's zoned in on this child's behavior. The next thing that we can do, once a child is about 6 months, 7 months of age, if they have good trunk and postural control and they have the ability to move their head, so it would be not a birth age necessarily, but a behavioral age. If they're able to do that, we can condition them to turn their head when they hear a sound by providing a visual reinforcement. And it's so fun to watch. So we used to have residents come into the clinics that we had, and they love to watch it because it's works like a charm, as long as the child is not crying and things like that, of course. So how do we do it? So in this picture here on the bottom left, the child is sitting on the mom's lap. There's a person in the booth who's trying to keep the child's focus to in front of them, because it's fun when they see these toys go off. So that sometimes they'll perseverate and just want to keep their head in anticipation of that reward. So we need something to center them and get them back to center. So what we do is we teach them to turn their head when they hear it by lighting up. It could be many different things. We have a Pooh Bear and a Tigger that light up. We have little things that like do on a drum. And then we're constantly trying to change the reinforcer to keep their attention. And so one of the things that we've had in recent years is we have video reinforcement. So every time the child turns, a little different animated video pops up, and it's different every time. And that allows us to get hopefully a complete audiogram by maintaining their attention. And we can do it through speakers in the sound field, but we can also do it delivering the sounds. We can condition them that way if they're having the little earbuds in as well. And one of the things too, if we don't have an extra tester, we usually will have a centering device of a little light up a ducky who will get their attention, will flash the ducky to get them back to center. But it works like a charm. The next thing we can do in early childhood, about the age of 2.5 years, cognitive age, about 2.5 years, we can teach them to do a game with us when they hear a sound. And so if you're ever doing a screening with children, and you have an audiometer and you want to try and get a child in between 2.5 to 4 to 5 years of age, you can teach them to play a little game. Now we're trained as audiologists to do it. And so what we do is, we have the headphones on, we have a task. So this little guy here on the left is putting a block in a bucket when he hears a sound. This one's doing the little rings. This one's putting a peg in a board. So we say, listen, and we're like, oh, I hear a birdie. And then we do hand over hand. We teach them when they hear a sound to do something. And again, it works like a charm. It's really fun. And again, to keep them motivated and going, we have lots of different toys that we use. If once they get tired of that, maybe they want to feed the monkey the banana. So they hold the banana and then we teach them and then they let us know. And what's really fun when you're working with kids is, because we do it, we teach them to hold their hand up from where they hear their sound. We don't tell them when we're switching, and then all of a sudden they'll go, and they'll put it over here. And that's just another way to know that it's a real response. And sometimes even anyways, when they hear a sound, they'll give a happy reaction. And then there's, of course, the regular pure tone audiometry. And that's when you get to the age of 4 or 5, where they can be taught when they hear a sound, raise your hand. 5-year-olds like to clap when they hear the sound. And of course, if it's an adult, there's a little button that they can press. Now, how do we graph hearing? We have what's called an audiogram. I would imagine most of you have seen this, but just a quick review. We have pitch or frequency going low to high as you go across to the right on the x-axis. And then here on the y-axis is loudness or intensity, and it's measured in decibels. So the lower you are in the graph, the louder things are. And you can see there's common sounds that are found on this graph and where they end up falling in the frequency spectrum and then also in intensity level. This little yellow area here, they call it the speech banana. It looks kind of a little bit more like a boomerang, but it does show in normal conversational speech where the sounds of the English language fall. And in the low frequencies, there are the vowels and some lower pitch consonants. The low frequency sounds of speech hold a lot of power. And the reason why I say that is the high pitch sounds are rather weak. And if you think of t and f and th and s, those are very weak high pitch sounds. The thing is, though, they carry a lot of meaning for speech. And this also shows you just the different levels, how we classify hearing loss: profound, severe, etc. We consider normal hearing for an adult 25 decibels or better, which means their symbols would be up here. But a child really is, we're looking for thresholds 15 decibels or better up in this area. In audiology, circles are always the right ear, X's are the left. This right here is normal hearing. So all of the thresholds are for a child better than 15. They're going to have no trouble hearing all of the sounds of speech. But if we look at this one, what's going on here? So this is a typical sloping hearing loss where there's better hearing in the low frequencies and it gets worse in the high frequencies. So on an average daily basis, when someone is talking, they are barely making out some low frequency information, but they're not hearing any of this speech information. And is there going to have a difficulty understanding? You betcha. In quiet and then also in noise. And some people say, oh, a high frequency hearing loss, they're fine. But high frequencies, like I said, carry a lot of the meaning and the specificity and the detail of speech. So I have a super short video, and I want you to pay attention. You're going to see on the audiogram, you're going to see the high frequencies start to go. And I really want you to notice when we get down to a moderate hearing loss, totally normal middle and low frequencies, but a moderate high frequency hearing loss, what it does to the sound.
1, 2, 3, 4, 5, 6, 7. Aha! You're on my apartment building on Granite Avenue. You owe me $300. Get it up?
Fred, take it easy. It's only a game.
Wilma, I'm just like them big tycoons. I play to win. Now, Barney, pay up or get out of the game.
That's 1 down and 2 to go. Betty, it's your turn.
I don't have any more money either. You got it all.
Then I'll take a mortgage on your open home. Well, come on, take the dice, will you?
All right, so you get the idea. So even though the hearing was pretty much normal in the low frequencies, again, they're hearing those sounds that provide power to speech, but the clarity of speech is missing with the high frequency. And high frequency losses are very common in individuals as we age. Those high frequencies have a tendency to go first, but also with noise exposure, damage that comes from consistent unprotected noise exposure, going to loud concerts and sitting by speakers and not protecting your ears. And you can see that's pretty significant. You get down into that moderate range and that's in quiet. It's very hard to understand. It just sounds garbled.
1, 2, 3.
Sorry. There we go. Okay, I'm just watching our time here. So another test that we do to help differentiate between a conductive hearing loss, meaning there's a problem in the external middle ear, versus a sensory neural hearing loss, which is in the cochlea, is we do something called bone conduction testing. And remember, what we hear is sound waves. And so if we skip sound going through the external and middle ear, like we use when we do that over-ear headphones, or if we do the little earbuds, if we skip those two parts of the ear and we stimulate the cochlea directly, which sits right behind our mastoid, we can differentiate the thresholds that we get between those two transducers. So here is a bone oscillator. And so it's delivering sound directly to the cochlea. And if you have this on, it just sounds like sound to you. But what's really important is we're going to take a measure with the headphones, and then we're going to compare the same thing with the bone oscillator. So this is an example of what we call a conductive hearing loss. That means that there's a problem in either the external ear or the middle ear. So if there's a child who has glue ear, chronic, and that is a very unhealthy middle ear, we might get a moderate conductive hearing loss. So that means with the earbuds, when we tested them, they had moderate hearing loss. But this is not real world because sound travels through our ears. But if we manipulate it and we stimulate the cochlea directly through bone conduction, we know that that cochlea is working fine. So the good news of that is typically a conductive hearing loss can be treated medically, and we know if they can fix that problem in the external or middle ear, we know that their cochlea is doing A-OK and they would have normal hearing if it can be successfully treated. as opposed to a sensory neural hearing loss, where the little symbols or these little caret marks represent what we're getting on the bone conduction. Those are matching up. So unfortunately, we know that this is a sensory neural hearing loss, and they can be helped with hearing aids, but there's not really a way to go ahead and fix it. If it's a profound hearing loss, we know that there are some people that can be helped by having a cochlear implant. And this just, again, gives you translating the numbers. If someone has a moderate hearing loss, they're going to have a hard time hearing just normal speech. Even a mild hearing loss, they're going to miss quiet speech. So I hate the word mild because it really isn't mild. There's still a significant effect with a mild hearing loss, and it's still very significant if there's a unilateral hearing loss, particularly with a child. It used to think, oh, they have one good ear, they're fine. But no, we need two ears for a reason. So you need two ears to localize sound, figure out where sound is coming from. Think of how important that is to a child. If they're playing outside and they run out in the street and they can't figure out where the sound of the car is coming from, it's very dangerous. But also in a learning environment, when there's any type of background noise, you have got to have two ears working together at the same level for that child to be able to understand. So if you ever notice when you're working with children and they seem to not know where sound is coming from, where if someone's talking over here and they're turning over here, a red flag should be saying, oh, I wonder if they're hearing okay in both their ears. I know can I keep going? I have just a few more minutes. Is that okay, Janelle?
Yep, go right ahead.
Okay. So it's very important for children and infants to be evaluated by audiologists who have expertise in testing infant and small children. And we do have a map for those of you who are in Utah that it has an interactive map across the state of where you can find these services. This is the actual map. So if you look at these green dots, these are where our infant and pediatric audiologists are in our state. And I would imagine with the other rural states that are on here, it may be very similar. So most of those audiologists are on the Wasatch Front, or, from Logan up in northern Utah down to Provo right here. And we do have a couple down here in St. George, but all the rest of the state, we don't really have access to these specialty services. So one thing that we do have, look how cute this baby is. So this little one's having an ABR test done. Is we do have tele-ABRs that are available. So if you look at the blue on our map now, these are where we have sites set up, where we have a facilitator at the clinic or the local health department who's trained to prep the child, put the electrodes on, and then one of our audiologists here will take over the equipment from Salt Lake City and run the test on the child. So here's an example. Here's Shannon. Shannon and Jenny do most of these, unfortunately, because I'm doing mostly administrative stuff. But this was a baby who was in the hospital. It was very medically fragile, and we were able to successfully get an ABR on her, and there's Shannon counseling the mom with the results. So if your states aren't doing that, it's definitely, we've been doing it for many, many years, and it works great. Just so you're aware, there are risk factors for hearing loss where children may pass newborn hearing screening and maybe develop hearing loss later. Any neonatal intensive care unit is a red flag. If there's any sort of family history in childhood, as we already mentioned about cytomegalovirus, children with Down syndrome are at higher risk because of their anatomy. They're more likely to have problems with middle ear fluid, but I want you to remember that 15% of children with Down syndrome also have a sensory neural hearing loss. So you never want to poo-poo, oh, well, they have Down syndrome, it's just middle ear fluid. Well, that's certainly not the case. There's plenty of research out there and data that we've collected as well that probably 1 in 7 actually have this underlying sensory neural hearing loss as well. There's a risk factor sheet that has a follow-up schedule on when audiology should be done for children that have a risk factor. It is in the position statement, and in the slides, it actually has a link if you want to look at this 44-page document. It also has a big section on what constitutes appropriate early intervention for children who are deaf and hard of hearing. And lastly, I just want to say how important early childhood hearing screening is. Do not hold your hat onto newborn hearing screening results. This is data that we've collected, and we found children identified with late onset hearing loss. There's a lot who will develop it up to the age of 3. The next category is up to the age of 6. And there's probably more. It's just probably we didn't get the results reported to us, but we do know that incidence of hearing loss will triple by school entry. So kindergarten is probably higher. And there are studies out there now that they're estimating about 15% of children who are age 6 to 19, so during those school age years, have hearing loss. Just when you're working with toddlers, some possible signs to pay attention to is lack of reaction to sound, isn't paying attention or able to figure out where sound is coming from. They were doing babbling and making sounds and some expressive communication, and then they stop. Or they're starting to produce speech utterances, but it's unintelligible. So it's not coming out clearly. And then in a school age child, it could be not following commands, oh, we're gonna go out to the playground, go and get your sneakers, and they're not following it up, or they're falling behind, or this is a big clue that they're just kind of acting up. They're not paying attention, and because it's hard, hearing loss is hard and it's exhausting on these little ones. And so they get tired of trying to pay attention, and if it's undiagnosed, they'll find something else to keep themselves busy. So if there's ever an issue of lack of attention or behavioral issues, you always got to be thinking, man, we better check their hearing. The American Speech Language Hearing Association has a great resource that lists communication milestones. You can click on the link. It'll give you some ideas on what that child, your child, or if a child you're working with, what they should be able to do. Again, you probably know all this because you're early childhood providers, but then it also has tips and tricks for parents as well and things to work on with their baby. And lastly, I just want to say we do have the Children's Hearing Aid Program here in our state. If you have a child under the age of 18, they have hearing loss. We do have a financial criteria. It is very broad, though. The family can have up to 300% of federal poverty guidelines and qualify for our program. We also cover the little ear molds, which are the pieces that we mold to attach to behind the ear hearing aids for little ones for 3 years. We'll pay for that. And then also soft band devices. This little guy has a bone conduction device. He has atresia, so he doesn't have an opening to his ear. So we're doing a hearing aid, but we're doing it by that bone conduction. And the little bands in that will also replace for the first 3 years as well. So just kind of keep that in mind. They do need to be a Utah resident, though. Here are resources for you guys. We do have pretty robust websites for EDI, for cytomegalovirus, and our children's hearing aid program. Here's our audiology service map. Here's more information about our parent consultants. They also have a very active page on the Utah Parent Center, which is who we contract with for their services. Any questions?
Wow, that was so much wonderful information, and thank you. So I am going to turn it open for questions. You guys can just raise your hand. I'll call on you or put it into the chat if you have any. We'll see, look at Stephanie, you just answered all of our questions. Oh, never mind. Kurt Phillips says, great explanation and examples. I've been doing EI for 25 years and learned a lot.
Well, that makes me very happy. So not only are you good at dad jokes, I'm glad I could give you a little bit of nugget of information even after your vast experience. So thank you.
Awesome. Okay, well, Kate, then I'm going to turn the time over to you and you're going to do our case and we'll hopefully discuss it.
Great. There we go. So yeah, like Stephanie had kind of shared already, this little guy that I'm going to present on, just had congenital CMV, and sounds like he's one of the 1 in 5, 1 in 4 that has a lot more going on with it as well. So yeah, I appreciate all your guys' help and insights because there is a lot going on. So a little background, he is now 27 months old. He was born early, 33 weeks. He has diagnosis of, I need to move this out of the way so I can see. So he does have a diagnosis of CP, congenital CMV. He had a stroke. He has a seizure disorder, is G-tube fed, and has vision. They're still trying to figure out all that's going on with vision, but they've noted a lazy eye and astigmatism in the left eye. And he was wearing glasses, and it sounds like he has been, I don't know, Stephanie did a great job of explaining like all the like deadlines and how they follow kids with the CMV and making sure they're getting all their hearing tests. It sounds like he has been doing all of that, but it was just his most recent ABR that showed the mild hearing loss in his right ear. And then he just recently qualified for a hearing aid. So he hasn't, that was just last month that we heard that. So I haven't heard any updates on where they are with moving forward with that. But I'm really intrigued now to see how that all turns out. And so I'm his occupational therapist on the team. He also has a physical therapist that he works with. And he's being seen by multiple specialists through USDB and their PIP program, their parent infant program. So he has a lot of people. Oh, and I should just add, I just got an email today saying that he has a speech language pathologist that will be added to the team now too. So we're going to be able to address language and communication a little bit more as well. So because of his CP, he has begun Botox in his legs, and they're considering to do it in his arms as well. He has quite a bit of tone that's impacting his arms and legs. He's on medications for seizures and recently a sleep medication and reflex medication. He's been having a hard time sleeping. And the seizures have been kind of the biggest kind of barrier right now. He had a pretty big episode where he was in the hospital for quite a while. They couldn't get his seizures under control. And so just in the last month or so, they've changed his medication and he's been okay. And he's actually thriving now. He's doing skills that we haven't seen in a long time. So this last month has been a really good month, which was really good because it was a hard summer for him and just managing the seizures. They also learned his G-tube just had an ongoing infection at the site that was likely contributing to the seizures. So the parents have had a lot on their plate in managing infection and going to wound care regularly, trying to figure out what's going on with the seizures, the sleep, all these things. And then when he got placed on a G-tube, he started growing weight, gaining weight rapidly. So he's now overweight, and they're trying to figure out how to manage his nutrition, like still meet his needs, but not, overdo it either. And so that's a little bit about him and his family. So he comes from a Caucasian family. He's an only child, and only his father is employed right now. His mom worked as a dental hygienist, but hasn't been able to go back to work since this little guy has been born. They're wonderful parents. They are incredibly resilient and fantastic advocates for their sons. He does outpatient therapy as well, and they've fired outpatient therapists that haven't been on their team. They felt like haven't been a good match, and they just do a really good job of making sure that their son is being taken care of, and really appreciate that. There is financial concern, of course. There's a lot of things that financially to support his medical needs. So they are always open to advice about how to get that financial support. So I'm going to look into that chat program to see if that would be something that would be good for them. So there's a lot going on, but kind of the three main areas of concerns that we're addressing are gross motor. So right now, he is sitting with minimal assistance, and his head control has improved significantly, which is good to see. He is starting to roll to his side, but we're not yet seeing a full like roll to belly to back kind of movement. And he's started to, this is a big thing, is bear weight on his feet when he's in a stander, which is really exciting. And I didn't finish that sentence, and I don't know where I was going with that sentence. So sorry about that. But we have a stander, and he has braces, ankle braces to support him. So the physical therapist has been just trying to support all those areas of development, continue to help with the rolling, the tummy time, the sitting without assistance. And he's kind of funny. I think I mentioned this later on. so tone comes in for sure, but his little personality comes in too, and into play. And if he's not having it, he's not having it, and he just will let go and just not even try. So he's a pretty funny kid and has a big personality, and will, and that affects how hard he wants to work for that day. With his fine motor, he is now consistently reaching with his right hand. That has been a big, big step for him, is to get that consistent reach. When he sees something he wants, he will reach with his right hand. He's pressing buttons, he's swatting at things. He likes things that light up and spin. And so he'll kind of swat at them to activate those toys. His left hand is not yet consistently reaching. And I think that's one of the reasons why they're considering Botox in the arm, is to help with that tone, because it's pretty tight. And when at rest, it's very, he does have an open hand and he's relaxed, but whenever he goes to activate even that right hand, you see that left hand kind of come in, and it could, that fisted position. So we've been trying to, work with that and getting him to reach with both hands, interact with things with both hands. And then communication, now that we have an SLP, that will be great to kind of help with that. But he has clear choice. He's clearly knows what he wants. Sometimes the motor component is hard in being able to reach for what he wants, to communicate what it is that he wants. And then in terms of sounds that he's making, he mostly kind of does these squills, cries, grunts kind of sounds. We're not yet seeing like true babbling or imitation of sounds. So that's something that we will continue to work on with the SLP. So his goals are to be independent in prop sitting, to reach with both hands and with his left hand more, recognizing names of familiar people and objects, so building that receptive language is things that we've been working on, and then communicating in any way that he can, whether it's reaching, switches, gestures. There has been a switch that has been brought in by USDB, but then the seizure started, so we haven't effectively implemented it yet, but I am curious to see how that goes. In terms of barriers, like I said, his mood for the day and how happy he is and how willing he is to participate. I feel like in home, like because we go into the home, he does so much better than his mom says he does much better with all his in-home therapists than the outpatient therapist. He's much more comfortable there. Tone and seizure management, and his G-tube wound has been a big barrier, a lot of medical stuff going on. And then learning his vision, like what his strengths are and how we can support his vision to be able to support his participation. So things we've tried, he has ankle braces, a standard, just got a gait trainer because now that he's weight bearing, he looks a little bit better. And then he just got a wheelchair a couple weeks ago and is looking really good in that. For his arms, we've done the bamboo elbow braces, if you guys are familiar with that, and then worked on supported seating with the tomato chair. And then I made a little box table thing that he can sit and play at. And then we just began to introduce switches, so for communication. Things that I would like additional support and ideas, really any ideas that come to your mind, I'd love to hear, but the motor aspect, so ideas for supporting the fine and gross motor skills, any other ideas that you have to be able to help with sitting, weight bearing, reaching, grasping objects would be helpful. Progress has been a little slower than sometimes as a therapist I'm comfortable with, so I feel like I get stuck, right? And I just need more ideas. So would love more input there. Ideas for supporting communication, expressive and receptive, given his motor, where he is at motorically. And then ideas for grants or community resources to help with accessing equipment, such as something they've talked about is like a vehicle that can support a wheelchair, because this is going to be long-term for them, right? And then any other things like the chat program for hearing aids, any kind of assistive devices. So those are, kind of the areas I would like support with.
Awesome. Thank you, Kate. Shelby had one question before I put everybody into their breakout groups. It just says, what about imitation of actions?
Mm. No,
Or
not
facial
yet.
expressions. Anything like that?
No,
No? Okay.
not yet.
Okay.
I mean, he loves when you're singing to him and he gets happy, but we're not really seeing like the imitation.
Okay, we're gonna go into breakout groups. We will move Kate in and out of breakout groups. Are they all closed, Shayna?
Yep.
All right. Okay, we have 3 minutes to go over one idea really quickly. So I'm not gonna start with Pat because she talks a lot. So Rebecca.
Okay. I think the one thing that I would just put out there is the idea of making sure that the family has an SSDI or SSI application going. And the thing that could potentially be tied to that would be using those funds to make payments on a wheelchair accessible van down the road. So that was a good idea.
Wonderful. Okay, Shelby, your group.
Kurt was our note taker. So
Okay,
Okay.
Kurt.
So we talked a lot about utilizing primarily around that one arm that's not being used a lot. Sensory, different sensory techniques, different, a play frame, something like that. Also talked about the controversial topic of constraint therapy to see if we could get them using that opposite arm, depending on the potential, I guess, for that the use of that arm.
Wonderful. Okay, Pat, wrap us up. And it wasn't you, so it was Heather.
Yes, yep. Okay, so really quick, engagement. So responding verbally, non-verbally to any communication attempts, even watching for eye gaze and being responsive there. Back and forth exchanges, being an animated play partner.
Wonderful. Man, Heather and Pat were in the same group. They're like so chit-chatty. I love them both, but that's why I can give them a hard time with it. Okay, so we are doing another hearing loss session next month. Shelby Clark from North Dakota will be talking to us about some hearing loss from an SLP perspective and different things of that. So hopefully we will see you guys all next month. We do have our 2025 registration that will be starting also. So look for that. We have some great sessions coming up. Thank you everybody for attending and enjoy the rest of your afternoon.